Hello, everyone. My name is Dr. Dan Milner. I'm an anatomic and clinical pathologist based in Southern California, and I'm happy to be one of the co-hosts along with our colleagues in Nigeria, Runsi and Gloria, for the Upgrade Oncology program and this series on pathology. This will serve as an introduction to the series for a few minutes. I'm doing it early so it can be recorded, so anyone who watches this later will see it. All the information that I'm going to provide for you is in all of the registration emails, but I just wanted to do a little housekeeping before we get started. So today we did start an hour late because we had a last minute cancellation, but normally for the next couple of weeks, it will be on Tuesdays and Thursdays at 3 p.m. local Nigeria time to 5 p.m. There will be 2 hours allocated each day, and typically there will be either one very long session from one speaker or possibly 2 smaller sessions from 2 speakers. On some cases, we have one long session, but it's 2 speakers who will tag team it. How the process will work is for each session, you will receive a registration link, or there's a registration link for the webinar. That will allow you to do a couple of things. The first is register with your email so we can track your progress in the course and make sure that you are getting your certificate at the end for your participation. The second is that we'll register you for that particular session and send you a specific link so that you can then join the session when it is live on that day. And the third is that there are pre-session questions that we ask that you answer. These are not graded. They're not going to be publicly announced as individuals. We just want to get a sense of the group, of your understanding of the material pre-seminar. And then we will send you a post-seminar survey with similar questions to answer. And our goal is to see if we're having impact on the group's knowledge, increasing their understanding of the topics at hand. The course looks like to be very exciting, and you may have seen an early version of the schedule because of the challenges of scheduling lots of different pathologists to be part of the seminar series, the webinar series. The order has changed a little bit, but what I will be sending out by the end of this week is a registration landing page. And on that page, you'll actually see every single session, who the speaker is, when it occurs, etc. And what we would ask you to do is register for each session about 48 hours beforehand. Don't do it any more in advance than that. And the reason being is that each time you register, you get a different unique link for that webinar. So if you register for all of them at once, you'll have a whole bunch of links in your inbox and you won't be sure which one you should use. So if you just register either the day before or 2 days before the actual event from that landing page, you will get the appropriate link and be able to join the session. All of the sessions are recorded, and those recordings are actually then posted back to that landing page that I will send you by this Friday. So what that means is that you only need to ever go to one location, which is the landing page, when you're ready to register for a new course or a new session, or when you want to watch an old session. And that so the registration link will turn into the recording link after the session is over. So it's all one-stop shopping on one page, and you'll be able to see everything there. So with that, I will let you know that the way that the webinar will work is that you have 2 options for communicating with the team. The first is through the chat. The chat allows you to post questions to the host and panelist or to everyone, and you should use that only if you're having technical problems, or if you can't hear, or if the slides aren't loading, something technical, let us know and we will fix that through the chat. However, there's also a Q&A button, and that is where you can post your questions. And we strongly encourage you to ask questions during the presentation. And what we will do is at the end of the presentation, we will answer as many of those questions live as possible. If we don't answer them live, we will ask the speaker to review them offline and provide answers, and we will send those to you in an email when we send out the the update for the course on what's coming up next. So you'll have all that information available. So I believe we have some people. It's now the actual time that we're supposed to start. We have a couple more people coming in, but I'm going to go ahead and introduce Dr. Nishino and his session, and then we'll get started so that he can move through his information. I have asked Dr. Nishino to pause between slides so that the slide will load for you if you happen to be watching this live. So when he changes slides, there will be a pause in his speaking. That's just so that the slide will load for you. So please just bear with us and have some patience. So thank you so much. So our first session today, Dr. Valeric is unable to do the head and neck. She will do that later in the course. We congratulate her on her new baby, but she is happy to do that a little bit later in June. So today we have just one session. This is Dr. Machia Nishino, MD, PhD, who is the director of head and neck pathology at the Beth Israel Deaconess Medical Center in Boston, Massachusetts, and he's an associate professor of pathology at Harvard Medical School. And his session today is a pattern-based approach to sinonasal pathology, which is obviously very important for our African population. So Dr. Nishino, I will turn it over to you.
All right, thank you so much, Dr. Milner, and hello, everyone. I'm so happy to connect with colleagues in Africa through this webinar series, and a big thanks to Dr. Milner and the ASCP for bringing us all together. And I hope all of you are as excited about sinonasal pathology as I am, because it is a fascinating area of head and neck pathology, in part because of the sheer variety of lesions that can occur in a relatively small anatomic compartment. And at the same time, it's that diversity of lesions that makes sinonasal pathology one of the more challenging aspects of surgical pathology. So over the next 50 minutes or so, our goal is to develop a practical pattern-based approach for recognizing important sinonasal lesions. And we'll stay mostly at the 30,000 feet big picture level to emphasize the diagnostic process while making sure to cover the key features of important lesions and some of their diagnostic pitfalls and pearls. We won't go take a deep dive into any particular lesion in particular. So to start with some context, the nasal and paranasal sinuses are midfacial cavities within the skull that extend all the way back to the skull base. And the four paranasal sinuses are paired diverticula that emanate from the central nasal cavity. And each of these sinuses are named after the bone in the skull that they occupy. So we have the frontal sinus and the frontal bone, ethmoid sinus and ethmoid bone, and so forth. Now, looking at this 3D model of the nasal cavity and the paranasal sinuses, here it's superimposed on this model of the skull here on the left, you can see how the frontal, ethmoid, and sphenoid sinuses form a saddle or a roof that sits on top of the nasal cavity. And if we rotate this model so that we're looking at the nasal cavity and paranasal sinuses head on, you can see how the maxillary sinuses flank the nasal cavity on either side. And if we turn this model a little bit further and look at the nasal cavity from the backside, we can see the left and right sphenoid sinuses as well from the rear. Now, histologically, the sinonasal tract is mostly lined by a ciliated, pseudostratified, columnar respiratory epithelium with a basal cell layer and occasional goblet cells, all sitting on top of a basement membrane layer. And there are often areas of squamous metaplasia as well. Beneath the surface, there are ceremucinous glands, which are essentially minor salivary gland tissue, located within a loose stromal and vascular tissue. And the number of these ceremucinous glands actually varies by site. And they're much more prominent in the nasal cavity and less prominent out in the paranasal sinuses. So knowing what components, cellular components are present in the sinonasal tract can help us develop our pattern-based approach. So basically, there are 5 patterns that I always think about when I approach a sinonasal specimen. Is it an inflammatory pattern, squamous pattern, glandular pattern, spindle cell pattern, or a small blue round cell tumor pattern? All right, so we'll start with the inflammatory pattern first, and we'll jump right into a medical emergency. All right, our patient is a man in his 50s. with a poorly controlled diabetes who presents in diabetic ketoacidosis, and imaging studies are suspicious for angioinvasive fungal disease. The sinonasal biopsy was densely inflamed. It's a very blue appearance from low magnification. But what sets this biopsy apart from the usual case of chronic rhinosinusitis is the presence of necrosis. Seeing necrosis and inflammation is a big red flag in sinonasal pathology, and really have to pay careful attention to the areas around the necrosis to see if it can point us towards a diagnosis. And in this case, we see fungal infestation within the necrotic area. And for this case in particular, the fungus showed broad aseptate or posiseptate hyphae with these wavy, uneven, ribbon-like walls characteristic of Mucorales species, confirming the diagnosis of invasive fungal sinusitis. The typical patient with invasive fungal sinusitis is immunocompromised, either due to diabetes. They classically present with diabetic ketoacidosis. They can have severe neutropenia from chemotherapy or from hematologic malignancy or acquired immunodeficiency syndrome. The big red flag to watch out for histologically is the presence of necrosis in the background of inflammation and hemorrhage. And in this context, the necrosis suggests an angioinvasive fungal disease, classically caused by Mucorales species, as in our case, but can also be caused by Aspergillus species as well. And in some cases, the fungal organisms can be seen on routine hematoxylin and eosin stains, but in case they're not readily identified, be sure to order fungal stains such as GMS or PAS so that you don't miss this critical diagnosis. As alluded to earlier, invasive fungal sinusitis is a true medical emergency requiring a rapid diagnosis so that aggressive debridement and systemic antifungal therapy can be initiated as soon as possible. But regardless of the treatment, the prognosis remains quite poor with high morbidity and mortality. All right, so that's invasive fungal sinusitis, a true medical emergency. Let's contrast that first case with this next one. There are some similarities. The patient is a man in his 40s from Vietnam who presented with facial swelling, and the otolaryngologist's exam favored a really bad case of chronic rhinosinusitis, and a sinonasal biopsy was performed. And that biopsy showed effacement of the sinonasal tissue by a blue and pink process here at low magnification. On higher magnification, the blue areas are a dense inflammatory infiltrate, and the pink areas are necrotic. So necrosis, inflammation, did you say? Bring on the bug stains, right? We got this. We know what the diagnosis is. In this case, though, the bug stains were negative, and one might be tempted, as I was for this case, to sign this case out descriptively as sinonasal tissue with inflammation and necrosis, suspicious for infection, but no organism seen. But if we did that, we would miss a critical diagnosis, and really the diagnostic pearl in this case is in the vessels. The vessels themselves are necrotic in this case, right? And you can tell because there's eosinophilic rim of fibrinous material lining the lumen of the vessels, or actually filling the vessels as shown here. So there's fibrinoid necrosis of the vessels. Here's another example of fibrinoid necrosis within the vessels, as well as some areas of neovascularization or recanalization, indicating a reparative change in response to damage to the vessels. So the vessels are really just reaching out, right, and telling us that this is an angiocentric and angiodestructive process due to invasion and damage of the vessels, not by fungus in this case, but by an atypical lymphoid infiltrate. And once we reach that point, we can use immunostains to show that these lymphoid cells express CD3, the T cell marker, CD56, which is a natural killer cell marker, and also are positive for Epstein-Barr virus, using in situ hybridization for EBV encoded RNA. There are also some cytotoxic markers like granzyme B and perforin that are positive as well, confirming the diagnosis of extranodal NK T cell lymphoma. It was formerly called the nasal type, but that terminology is no longer endorsed by the 5th edition of the WHO. So it's extranodal NK T cell lymphoma. Extranodal NKT cell lymphomas, they're most commonly seen in Asian populations as well as in Central and South American populations. And these are highly aggressive tumors that can cause midfacial destruction as well as orbital swelling and obstructive symptoms. Some of the key features to look for histologically include necrosis due to an angiocentric and angiodestructive infiltrate of atypical lymphoid cells. NKT cell lymphomas are positive for EBV, which can be detected by in situ hybridization for EBV-encoded RNA. They are also positive for natural killer cell markers like CD56 and T cell markers. And some of those cytotoxic T cell markers include TIA1, granzyme B, and perforin. And importantly, these NKT cell lymphomas are positive for cytoplasmic CD3, the T cell marker CD3 by immunohistochemistry. But if you do flow cytometry on these specimens, they're often negative because the surface expression of CD3 is not there. So in addition to these immunostains, they can point us in the right direction, but many of the clinical and histologic findings in NKT T-cell lymphoma can overlap with an autoimmune vasculitic process as well, known as granulomatosis with polyangiitis, formerly known as Wegener's granulomatosis. So serologic testing for ANCA can be helpful for this differential diagnosis. Patients with NKT cell lymphoma are typically ANCA negative, while those with granulomatosis with polyangiitis are ANCA positive. So here's the checklist that always goes through my mind when I see necrosis and inflammation in a sinonasal biopsy. A big red flag should go up in all of our minds when we see the blue and pink pattern of necrosis and inflammation. And think about an infectious process, invasive fungal sinusitis, and order a panel of bug stains, including GMS and PAS. Think about NKT cell lymphoma and order the appropriate NKT cell markers as well as EBER in situ hybridization. And at the same time, recommend ANCA serology to rule in or out granulomatosis with polyangiitis. All right, so that's the inflammatory pattern, the key things I wanted to cover there. So let's move on to our second pattern of squamous lesions. And of course, squamous cell carcinoma is the major disease that comes to mind for this pattern. But for the purposes of today's discussion, we're going to focus on squamous papillomas of the sinonasal cavity instead. And I'll share a game that I've had our trainees play here called Name That Sinonasal Papilloma. So what I'm going to do is I'll show you a sinonasal papilloma, and your job out there is to think about what subtype of sinonasal papilloma it is. All right, so we'll start with the first example. This is a polypoid mass. It has an undulating cerebriform exterior, and on cut section has a complex ribbon-like strips that's visible. It sort of resembles the cut section and the exterior surface of a cauliflower. And histologically, those ribbon-like areas correspond to strips and islands of non-keratinizing squamous epithelium with these smooth, rounded, bulbous contours. And the epithelial proliferation, it begins at the surface, doesn't it? And it invaginates or inverts downward into the subjacent stroma. And looking at higher magnification, the squamous epithelium, it's stratified, it's non-keratinizing, and has an immature or transitional appearance. And even from this power, I think we can see how there's a lot of intraepithelial neutrophils. And you can also see little microabscesses formed by groups of neutrophils sitting in these little intraepithelial pockets. And scattered mucocytes are present as well, reflecting the origin of this papilloma from that surface respiratory type sinonasal mucosa. So what sort of name would you think about to give to this papilloma? And if you're thinking inverted type of papilloma, you'd be correct. So this is a sinonasal papilloma inverted type. Inverted papillomas typically occur on the lateral wall of the nasal cavity as well as the paranasal sinuses. And the data is a little bit mixed on whether human papillomavirus plays an etiologic role, but there is a lot of convincing evidence from genotyping studies that most inverted papillomas are associated with EGFR mutations. So a follow-up question. If you see a case of inverted papilloma at the microscope, prior to signing out the case, we have to make sure that the prosector, the person grossing the specimen, has done this. And the answer is you have to submit it all. And that's because inverted sinonasal papillomas have a risk of malignant transformation. It's a low to intermediate risk, estimated to be 5 to 15%, that undergo malignant transformation. And among cases of malignancy associated with inverted papillomas, you can actually find the remnant inverted papilloma component in about 70% of cases. So if you're looking at a small piece of an inverted papilloma, to make sure that we're not examining a case that is harboring a concurrent cancer, we really are obligated to examine the entire inverted papilloma specimen histologically. All right, so that's an inverted papilloma. Let's take a look at a second type of papilloma. So here, in contrast to the prior case, this papilloma has a much more frond-like architecture with fibrovascular cores, more closely resembling broccoli rabe, rather than the cauliflower-like appearance of inverted papillomas. But similar to that case of inverted papilloma that we just saw, this papilloma also has cystic spaces. There's scattered intraepithelial neutrophils, there's microabscesses, and there's mucus cells as well. So what would you call this type of sinonasal papilloma? Not the inverted type, but the exophytic type of sinonasal papilloma. The exophytic type of sinonasal papilloma, they occur centrally along the nasal septum, along the midline, and they're associated with low-risk human papillomavirus, much like squamous papillomas from any other site of the aerodigestive tract. And in contrast to inverted papillomas, exophytic papillomas have a negligible risk of malignant transformation. All right, so that's exophytic papilloma. Our third and final type of sinonasal papilloma can have a mixture of growth patterns. It can be both inverted, downwardly growing into the stroma, or it can have an exophytic growth pattern. But what sets this papilloma apart from the two prior ones is the cytomorphology. These fibrovascular cores are lined by stratified layers of cells with abundant eosinophilic cytoplasm, and they're also dotted by these cystic spaces, as shown by these arrows. And here on higher magnification, note the multi-layered tall cells with abundant pink cytoplasm, its granular texture, dotted with these microcystic spaces. All right, so what would you call this sinonasal papilloma with abundant pink cytoplasm? And if you're thinking the oncocytic type of sinonasal papilloma, you would be absolutely right. Oncocytic papillomas are driven by KRAS mutations, and like inverted papillomas, they tend to occur on the lateral walls of the nasal cavity and out in the paranasal sinuses. And same bonus question, prior to signing out a case of oncocytic papilloma, we have to make sure that we've done this, and that's submitting it all. We got to submit it all because oncocytic papillomas have that low to intermediate risk of malignant transformation, similar to inverted papillomas. And as an example, here's a pretty recent case of a squamous cell carcinoma, as you can tell in these bluer areas, that arose in association with an oncocytic papilloma. And the transition between the oncocytic papilloma and the carcinoma is quite abrupt, as shown in these areas with the arrows. And seen on higher magnification here, you can see the sharp demarcation between the oncocytic papilloma here on the left and the squamous cell carcinoma here on the right. Elsewhere in the specimen, there were also areas of frankly invasive keratinizing squamous cell carcinoma with a desmoplastic stromal response as well. So overall, inverted papillomas and oncocytic papillomas have a lot of features in common, don't they? They have a similar location, they have a similar risk of malignant transformation, and they're associated with driver mutations such as EGFR and KRAS. And in contrast, the exophytic type of papillomas usually occur at the midline and the nasal septum, and they have a negligible risk of malignant transformation and are associated with low-risk human papillomavirus, similar to squamous papillomas from other sites of the body. All right, so that's a brief overview of the squamous pattern with a focus on squamous papillomas. Let's move on now to glandular lesions. And for this pattern, for our discussion today, we'll focus on malignant ones. And it's so helpful to remember the normal histology in terms of glandular lesions. There are really just two sources of glandular lesions within the sinonasal tract: the surface epithelium and the seromucinous glands that are below it, which histologically resemble minor salivary gland tissue. Now, most adenocarcinomas that arise in the sinonasal tract are derived from the ceremucinous or minor salivary glands. And at this site, adenoid cystic carcinoma is the most common type. And we'll touch a little bit on adenoid cystic carcinoma briefly in the upcoming slides. But first, we'll focus on these non-salivary gland type tumors that are derived from the surface epithelium. And these are further subclassified as being intestinal type or non-intestinal type adenocarcinomas. And we'll begin with the intestinal type of adenocarcinomas first. Sinonasal intestinal type adenocarcinomas were so named because of their resemblance to colorectal or gastrointestinal adenocarcinomas. And their growth patterns range from colonic, with these papillary patterns, to more colonic tubular patterns, as shown here, to higher grade areas with a more solid pattern. There are some cases of intestinal type adenocarcinomas with a prominent mucinous pattern as well, with these strips and clusters of tumor cells floating in abundant extracellular mucin. Similar to colon adenocarcinomas, we grade sinonasal intestinal type adenocarcinomas as low to intermediate to high grade based on their architectural and nuclear patterns. Now, in terms of immunostains, sinonasal intestinal type adenocarcinomas are generally positive for cytokeratin 7, CK7, and CK20. And like colorectal adenocarcinomas, sinonasal intestinal type adenocarcinomas also express SAPB2 and CDX2 as well. There is a really interesting occupational exposure associated with sinonasal intestinal type adenocarcinomas. It's classically linked with long-term, meaning decades, of exposure to wood dust in the woodworking industry, such as hardwood floor laying or furniture making, as well as dusts from the shoemaking and leather industry. So keep this checklist in mind when you're dealing with a sinonasal adenocarcinoma. If the histology and the immunophenotype resemble that of colorectal adenocarcinoma and you've excluded the possibility of metastasis from the GI tract, then you can report it as sinonasal intestinal type adenocarcinoma with the appropriate grade, low, intermediate to high. All right. So for sinonasal adenocarcinomas that do not have features of salivary gland tumors nor intestinal type tumors, the default or exclusionary diagnosis becomes non-intestinal type adenocarcinomas, for lack of a better name. The sinonasal non-intestinal type adenocarcinomas can have complex papillary or glandular growth patterns, and examples of low-grade non-intestinal adenocarcinomas like this one are characterized by a columnar or to cuboidal cells with round, bland, basally oriented nuclei. An occasional mucinous differentiation and clear cell morphology can be seen as well. Non-intestinal type sinonasal adenocarcinomas are typically positive for cytokeratin 7, but negative for CK20. And this negative CK20 pattern, together with the absence of CDX2 staining, helps distinguish this tumor from intestinal type of adenocarcinoma. And interestingly, some non-intestinal adenocarcinomas are positive for DOG1, as shown here, as well as SOX10, which might suggest some seromucinous differentiation in a subset of these tumors. So if you ever come across an adenocarcinoma in the sinonasal tract that doesn't quite fit the morphology and immunophenotype of a salivary gland tumor, nor the intestinal type of adenocarcinoma, then consider the exclusionary diagnosis of non-intestinal type sinonasal adenocarcinoma and grade it as low or high grade based on the usual nuclear and architectural features. So a quick pop quiz. We have two sinonasal adenocarcinomas here. And one of them is positive for CK7, negative for CK20 and CDX2. The other is positive for all three of these markers. So which one of these is the intestinal type of adenocarcinoma? The one on the left or the right? And if you said the one on the right, you're correct. Yeah, the image on the left is an example of a non-intestinal type adenocarcinoma, and the one on the right is intestinal type. All right, so that's all we're going to cover for now for the glandular lesions. So let's move on to some examples of the spindle cell pattern. Now, Many spindle cell lesions in the sinonasal tract, such as schwannomas, spindle cell squamous cell carcinomas, melanoma, solitary fibrous tumor, and so forth, they're really not specific to the sinonasal tract. So for today's discussion, we're going to highlight a pretty recently described sinonasal specific sarcoma that was added to the latest WHO Blue Book. And that's biphenotypic sinonasal sarcoma. This tumor has an almost warty exophytic growth appearance, and microscopically, they're composed of a highly cellular spindle cell pattern with intersecting fascicles, as shown here on the left, which occasionally form these long fascicular herringbone or fishbone-like patterns. The spindle cell proliferation in biphenotypic sinonasal sarcomas are characteristically associated with these invaginated and entrapped sinonasal surface epithelium, and the surface epithelium can become hyperplastic as well. These glandular areas, these are non-neoplastic. They're entrapments of the background normal respiratory epithelium. The nuclei of the sarcoma, they're elongated, they're bland appearing, and they have that waviness which suggests nerve sheath differentiation. By immunohistochemistry, these tumor cells show evidence of both neural crest and myogenic differentiation, and based on the expression of S100 and smooth muscle actin, respectively. And that's the rationale for the biphenotypic term. They show dual kind of neural and myogenic differentiation. These tumors are characterized by recurrent PAX3 rearrangements, the most common partner being NAML3, and the less common ones including NCOA1 and FOXO1. In general, biphenotypic sinonasal sarcomas are low-grade tumors. They're treated by local excision, and some patients receive additional adjuvant radiation therapy. Local recurrences have been reported in about 40% of cases. There's one report of death to disease due to recurrence, but no metastases have been reported to date. So overall, considered a low-grade tumor. All right, so that's that one example of the spindle cell pattern that we'll cover today. All right, so moving on now to our final pattern, which is small blue round cell tumors. And if you were a kid growing up in the 1980s like I was, what comes to mind when you think of small and blue? Smurfs, of course. And here they are reminding us that small blue round cell tumors of the sinonasal tract fall into two basic camps, those that are cytokeratin positive and those that are cytokeratin negative. And we'll start with the cytokeratin positive group first. We can further subclassify cytokeratin positive tumors, cytokeratin positive blue round cell tumors specifically, based on the expression of neuroendocrine markers and squamous markers. And I rely on synaptophysin and chromogranin for my neuroendocrine markers. And if available, the relatively new marker, INSM1, could be used as well. There are some pitfalls in using CD56 as a neuroendocrine marker, which we'll discuss in a moment. For squamous markers, I currently prefer P40, but P63 can be used in most circumstances as well. So among cytokeratin positive tumors, P40 expression can range from strong and diffuse staining on one end of the spectrum to this unique pattern of a basal or peripheral layer of staining pattern to cases with little to no staining at all. And similarly, expression of the neuroendocrine markers can vary from negative all the way up to definitively positive. So based on where a case falls within this matrix, we can classify most of these cytokeratin positive small blue round cell tumors. So for instance, here's a blue round cell tumor, pretty undifferentiated appearing. It was keratin positive, so we know it's a carcinoma, likely, and it showed strong diffuse expression for P40. Synaptophysin, as the neuroendocrine marker, was negative. So the final diagnosis in this case was a non-keratinizing squamous cell carcinoma, occupying this spot in the matrix, where there's strong P40 staining and absence of any neuroendocrine marker staining. That's very characteristic of non-keratinizing squamous cell carcinoma. Now let's move on to another blue round cell tumor. It looks morphologically quite similar, doesn't it? But in contrast to the last example, there are some subtle areas of duct formation highlighted here by the arrows. In the P63 or P40 staining pattern, it's restricted to the periphery of these tumor nests. So this basal pattern of staining is consistent with a solid type of adenoid cystic carcinoma. Squamous cell carcinoma will show a much more diffuse pattern of P40 or P63 staining. So the diagnosis in this case, solid pattern of adenoid cystic carcinoma. So a blue round cell tumor with this basal pattern of P40 or P63 and absence of neuroendocrine markers, think about the solid type of adenoid cystic carcinoma. Now, there is a pretty recently described entity within sinonasal pathology with some morphologic overlap with adenoid cystic carcinoma called HPV-related multiphenotypic sinonasal carcinomas. And these tumors, they're highly cellular, basaloid, and often have a solid growth pattern with occasional cystic areas that are filled with myxoid matrix material. And there are also some cribriform areas that resemble adenoid cystic carcinoma. And in fact, an early name for this lesion was HPV-related carcinoma with adenoid cystic-like features, but that name was superseded by the multiphenotypic term in the current WHO. Most cases show surface epithelial dysplasia as well. And as you might expect from an HPV positive tumor, these tumors are positive for P16 and high risk HPV. It's usually HPV type 33. And staining for P40, if present at all, is limited to the periphery or basal layer, really helping us to exclude a squamous cell carcinoma. So if you come across a sinonasal tumor that has surface epithelial dysplasia, it looks like carcinoma in situ at the surface, and it's a basaloid tumor that has histologic resemblance to adenoid cystic carcinoma, order a P16 and test for high-risk HPV using a panel that includes HPV type 33. And you can help confirm the diagnosis of an HPV-related multiphenotypic sinonasal carcinoma. And it's important to recognize this entity because the largest case series so far, which was 49 cases, indicate that in spite of the very high-grade microscopic appearance in the advanced stage that these patients present in, these tumors seem to behave better compared to other poorly differentiated sinonasal carcinomas. About 40% of cases recur. Distant metastasis is rare, and no death due to disease has been reported to date. So it's important to distinguish this HPV-related multiphenotypic carcinoma from sinonasal undifferentiated carcinomas, or SNUCs. All right, so our next small blue round cell tumor looks unsurprisingly very similar. It's a high-grade basaloid tumor with numerous mitotic figures and numerous apoptotic bodies as well. All right, it's a cytokeratin positive tumor, and we apply the two main stains, P40 and synaptophysin. This case, in addition to the strong cytokeratin staining, shows diffuse expression of synaptophysin, and it's negative for P40, diagnostic of a small cell carcinoma, which can occur in the sinonasal cavity. So small cell carcinoma occupies this portion in the matrix, or this spot in the matrix, where it's positive for neuroendocrine markers and negative for P40. All right. Now moving on to our next case, it consists of sheets of uniform, poorly differentiated cells with no evidence of glandular or squamous differentiation. The tumor cells have high nucleus to cytoplasm ratios. It has open chromatin patterns, prominent nucleoli, mitoses and apoptotic bodies are numerous as well. The pan-cytokeratin was positive, but P40 and synaptophysin are both negative, as well as some other ancillary stains listed down below. So morphologically, undifferentiated sinonasal carcinomas that cannot be further classified are currently diagnosed as sinonasal undifferentiated carcinomas, or SNUC, putting us at this spot in the matrix among cytokeratin positive tumors. SNUCs have historically been a diagnosis of exclusion in our practice, and for that reason, these diagnoses have traditionally been applied to a pretty heterogeneous group of morphologically undifferentiated carcinomas. But morphologic and molecular profiling over the past couple of decades has shown that tumors that have historically been diagnosed as SNUCs can be split into a number of molecularly defined entities. And these include nut carcinomas, defined by a gene rearrangement including the nut gene on chromosome 15. And there are also several sinonasal carcinomas that are defined by loss of components of the switch-SNF chromatin remodeling complex, such as SMARCB1 deficient carcinomas, SMARCA4 deficient carcinomas. There are also IDH mutated sinonasal carcinomas and a type of Ewing's family tumor, adenoamantinoma-like Ewing's family tumor that can be driven by EWSR1 rearrangements as well. So just keep in mind that a lot of tumors historically classified as SNUCs have a more specific molecular diagnosis these days. All right, so now we're going to move on to the second main group of small blue round cell tumors, those that are cytokeratin negative. And for these cytokeratin negative small blue round cell tumors, there are 5 main differential diagnoses that I always consider: melanoma, lymphoma, olfactory neuroblastoma, Ewing's family tumor or Ewing sarcoma, and alveolar rhabdomyosarcoma. And I know we talked a little bit about Ewing sarcoma as being cytokeratin positive, but a lot of them are cytokeratin negative as well. So we'll focus on olfactory neuroblastoma first, because it's the only one of these 5 cytokeratin negative tumors that is unique to the sinonasal tract. Olfactory neuroblastomas arise from the olfactory neuroepithelium located in the superior portion of the nasal cavity. And these are polypoid lesions with a grayish tan cut surface. It has some vessels that you can see coursing through it. It has a vascular cut surface. Microscopically, lower grade olfactory neuroblastomas classically show this lobular or nested growth pattern within this vascularized stroma. Low-grade tumors are cytologically bland and uniform, with round nuclei and coarsely granular chromatin with that salt and pepper type chromatin pattern and indistinct nucleoli. About a third to a half of olfactory neuroblastomas can show this cuffing or palisading of these bland cells around neurofibrillary stroma. So these are the Homer-Wright pseudorosettes, and these are more commonly seen in low-grade olfactory neuroblastomas. In contrast, higher grade olfactory neuroblastomas have a less overtly lobular growth pattern. It's much more sheet-like in growth, and they occasionally demonstrate a well-defined duct-like luminal spaces with a true duct, and these are called the Flexner-Wintersteiner or true rosette-like structures seen in higher grade olfactory neuroblastomas. Now, importantly, olfactory neuroblastomas are negative for cytokeratin. It's one of the 5 cytokeratin negative blue round cell tumors that we see in the sinonasal cavity. And they're positive for synaptophysin and chromogranin. And the negative keratin staining here is important because it helps distinguish olfactory neuroblastomas from neuroendocrine tumors like small cell carcinoma. S100 typically highlights the support cells or sustentacular cells located at the periphery of these lobules, and an immunostain for SOX10 would show a similar staining pattern. As alluded to before, olfactory neuroblastomas arise from the olfactory neuroepithelium located in the upper portion of the nasal cavity. So it makes sense that olfactory neuroblastomas typically occur at these sites in the superior portion of the nasal cavity, including the cribriform plate. And radiologically, olfactory neuroblastomas are classically described as having a dumbbell-like shape because the tumor can extend upwards into the anterior cranial vault, and it can also extend downwards into the nasal cavity with a constriction, where the dumbbell handle is at the cribriform plate. It's important to keep in mind that olfactory neuroblastomas are neuroectodermal rather than neuroendocrine neoplasms because the general treatment approach may vary between the two. The optimal treatment of olfactory neuroblastomas has not really been established in randomized controlled trials because of the rarity of this tumor, but the mainstay of treatment for olfactory neuroblastomas is surgical, often with adjuvant radiation therapy. In contrast, chemotherapy is the mainstay of treatment for neuroendocrine carcinomas. We grade olfactory neuroblastomas using Dr. Vincent Himes' 4-grade scheme. And just conceptually, overall, low-grade tumors have that lobular architecture with abundant fibrillary stroma, while high-grade tumors have that more sheet-like, less overtly lobular architecture and limited to no stroma. Homer-Wright pseudorosettes with central fibrillary stroma are seen more often in low-grade tumors, while the Flexner-Wintersteiner rosettes with true canals are characteristic of higher-grade tumors. And increasing degrees of mitoses, necroses, and nuclear atypia can be seen as we move along this grading spectrum. Now, before diagnosing olfactory neoplasmomas, you can go through this following mental checklist. Have to confirm that it's cytokeratin negative and that it's positive for neuroendocrine markers or neuroectodermal markers like synaptophysin and chromogranin. And seeing a sustentacular staining pattern with S100 or SOX10 can be helpful to confirm the diagnosis, especially in lower grade tumors. We also ought to check the imaging studies to confirm that it involves the upper portion of the nasal cavity. And once all these criteria are fulfilled, we can top-line the case as olfactory neuroblastoma and give a grade. There's no synoptic reporting that's indicated for olfactory neuroblastoma. All right, so the remaining 4 items in the cytokeratin negative small blue round cell tumor differential are not really specific to the sinonasal tract. We covered lymphoma already in our discussion of NKT cell lymphoma, so we'll go briefly through the other 3. Mucosal melanomas, they can be morphologically variable. It can be spindled, it can be epithelioid, and apropos our discussion, it can be a blue round cell tumor as well. Here's an example of a sinonasal mucosal melanoma with sheets of tumor cells with scant cytoplasm. It was negative for cytokeratin and negative for CD45, helping to exclude a carcinoma and excluding melanoma. And it was positive for melanocytic markers, including S100, SOX10, melan-A. So the checklist for mucosal melanoma include confirming the diagnosis using melanocytic markers. We should also clinically exclude metastasis from a cutaneous melanoma so that the patient can be staged appropriately. And with respect to stage, mucosal melanoma has a very poor prognosis overall. The staging begins at T3 for disease that's limited to the mucosa. And for tumors that extend into the dura, the brain, the skull base, and cranial nerves, that's considered locally advanced disease and are staged as T4A or B, respectively. All right, so now moving on to alveolar rhabdomyosarcoma. So once again, unsurprisingly, this is a small blue round cell tumor that effaces the sinonasal mucosa. It has a pretty primitive, undifferentiated morphology with open chromatin, scant cytoplasm. It's negative for cytokeratin. It's one of our 5 cytokeratin negative tumors. It's positive for myogenin and desmin, indicating that this is a malignant tumor with skeletal muscle differentiation, confirming the diagnosis of alveolar rhabdomyosarcoma. Alveolar rhabdomyosarcoma typically arises in young patients with a peak age between 10 and 25 years, and it has a very poor prognosis overall. The 5-year survival is 40 to 45%. Most cases of alveolar rhabdomyosarcoma harbor a gene rearrangement involving the FOXO1A gene on chromosome 13. The PAX3 FOXO1A fusion is the most common, and PAX7 is a less common fusion partner. And about 20% have no known fusion or translocation. Now, we talked a little bit about CD56 as a potential pitfall. And one potential pitfall with this stain is that alveolar rhabdomyosarcomas are positive for CD56, but we really have to be careful when using this stain, especially in the sinonasal tract, because there are a number of tumors in the differential diagnosis of blue round cell tumors in the nasal cavity, including 3 alone that are negative for cytokeratin. So in addition to alveolar rhabdomyosarcoma, NKT cell lymphomas are CD56 positive. Olfactory neuroblastomas can be CD56 positive as well. So overall, I moved away from using CD56 in the sinonasal tract in favor of more specific markers. But if you do use this marker, be sure to interpret the CD56 positivity in the context of more specific markers as well. And finally, to round out our discussion of cytokeratin negative blue round cell tumors, Ewing family tumors are characterized by fusion of the EWSR1 gene to one of the members of the ETS family of transcription factors. And much like the other small blue round cell tumors that we looked at today, these are cellular tumors with a sheet-like growth pattern, has a primitive appearance with scant cytoplasm, ovoid to round nuclei, pale chromatin, and variably distinct nuclei. And Homer right rosettes can sometimes be seen in these cases, in these tumors as well. The fusion partners for EWSR1 include the ETS family transcription factors such as FLY1 and ERG, among others. By immunohistochemistry, these tumors typically show strong, diffused membranous staining for CD99, as well as nuclear staining for FLY1, if that's the fusion partner, and NKX2.2, which are regulated, which are upregulated downstream of the EWSR1 translocation. Notably, cytokeratin staining can be variably present in Ewing sarcoma, with staining reported in up to a third of cases. So it's not strictly in the cytokeratin negative camp, so be sure to keep that in mind. So in terms of stains, in addition to markers like CD99, FLY1, and NKX2.2, keep in mind the Ewing family tumors can be variably positive for cytokeratin, neuroendocrine markers, sometimes even Desmond and P40 as well. And in particular, there's a specific subtype of Ewing sarcoma known as the adamantinoma-like Ewing sarcoma that shows the molecular and histologic features of Ewing sarcoma. It has a basaloid blue round cell tumor appearance, but they can be potentially misdiagnosed because they are strongly positive for cytokeratin. They can be positive for squamous markers like P40 and P63, and can be positive for neuroendocrine markers as well. So to help prevent underdiagnosing or misdiagnosing this diagnosis of adamantinoma-like Ewing's family tumor, I always include CD99 in my initial immunostaining panel for blue round cell tumors, and would follow up with more Ewing's sarcoma specific markers or FISH staining for EWSR1 rearrangement if the CD99 shows strong diffuse membranous staining. All right, so that brings us to the end of our pattern-based discussion. So before I wrap up with my final slide, I'd like to just invite any questions from the live audience here. See if there's anything in the chat or in the Q&A. So there's a question saying, how can I differentiate it from synovial sarcoma? I think this might be referring to the case of biphenotypic sinonasal sarcoma that I showed earlier. And that's an excellent question from Umar Mohammed. So the main way to differentiate it from synovial sarcoma is the translocation. The PAX3 rearrangement is characteristic of the biphenotypic sinonasal sarcoma, whereas synovial sarcoma will have its characteristic translocation. And you know, one of the tricky things about a biphenotypic sinonasal sarcoma is its association with the epithelial invaginations, and that epithelial component can really mimic the biphasic appearance that synovial sarcomas can have as well. So excellent question. The dual myogenic differentiation, the S100 and the SMA staining, can also help us recognize the biphenotypic sinonasal sarcoma as opposed to synovial sarcoma as well. And if there's any question, doing the fluorescence in situ hybridization to look for the PAX3 translocation can be helpful. So thank you for that question. So another question from Dada Suleiman. It says, in a limited biopsy and in the absence of IHC, how will you advise we word our reports in the case of sinonasal mesenchymal proliferations? Terrific question. You know, in the absence of IHC, where we can't characterize it further, it may be perfectly reasonable to convey whether it's a low grade versus high grade spindle cell proliferation. And you might be able to use clues like the wavy nuclei that we can see on high magnification to say it's showing neurogenic differentiation, and to suggest something like biphenotypic sinonasal sarcoma, especially in a limited biopsy. If there's a radiologic correlation that you can make, if it's a very well demarcated small tumor with low grade cytomorphology, you know, that may be enough to encourage surgical resection to get more tissue beyond the limited biopsy sample. And of course, saying that it's a a high-grade malignancy with brisk mitotic activity and necrosis can be helpful for guiding treatment as well. So thank you for that question. So in terms of the reporting, saying low-grade spindle cell proliferation or high-grade spindle cell proliferation may be about as far as we can get without additional ancillary studies. All right, any other questions? One question that I often get from the audience is, when you have a small blue round cell tumor, what sort of immunostaining panel do I start off with? So the three that I start off with often is cytokeratin, P40, synaptophysin. To decide if it's a cytokeratin positive or negative tumor. If it's cytokeratin positive, then doing P40 and synaptophysin can help refine the differential further. And then for the cytokeratin negative tumors, the S100 or SOX10 can be helpful. Desmin, CD45 for lymphomas, CD99 for the Ewing's family tumor. All right, so I see a question from Dr. Rashid. It says, can fibrosarcoma be a differential diagnosis of sarcoma of the nasal cavity? So yeah, terrific question. From my reading of the literature, the cases of biphenotypic sinonasal sarcoma, a subset of them were previously diagnosed as low-grade fibrosarcomas. So yeah, definitely, based on histologic criteria, fibrosarcomas can be entertained in the differential diagnosis. And it's really that dual myogenic and neural differentiation, the SMA positivity and S100 positivity, as well as the PAX3 rearrangement that can help set the biphenotypic tumors in a separate category. In the Hymes grading in neuroblastoma, does it have prognostic significance? As far as I know, it does, and especially at the low grade versus high grade cutoffs. And there's some question about whether the high grade olfactory neuroblastomas, they actually represent, especially their subsets with a cytokeratin positivity that that have been called high grade olfactory neuroblastomas, whether they represent a carcinoma instead of a neuroblastoma. But Hymes grading, we do it here so that it helps prognosticate the tumor. The next question says, how common are intestinal type mucinous adenocarcinomas, and how can we differentiate this from mucoepidermoid carcinoma, especially when the squamous component of the latter are limited? What a wonderful question. These intestinal type adenocarcinomas or just sinonasal adenocarcinomas arising from that surface respiratory mucosa are pretty uncommon. The types, like a mucoepidermoid carcinoma would be much more common, to answer your specific question. Those that arise in the minor salivary gland tissues. I guess one way you could try to differentiate is to see if the tumor is arising from the surface as opposed to the subepithelial minor salivary gland tissue. So, in this diagram here, is it a tumor arising from the surface epithelium, which would be more characteristic of intestinal type adenocarcinoma, or is it one that really shows a derivation from these seromucinous glands below? So that could be one helpful way. If you are thinking intestinal type, they often have these elongated cigar-shaped nuclei. We really don't see that in mucoepidermoid carcinoma. The mucinous cells or the mucus cells of mucoep often have pretty small, nondescript ovoid nuclei, as well as the epidermoid compartment, the epidermoid component, and intermediate cells, which look kind of like squamous metaplastic cells. So, yeah, those cytomorphologic features can be helpful to distinguish those two. The next question, how do we differentiate adenoid cystic carcinoma from that HPV-associated sinonasal carcinoma? Yeah, terrific question. And, I think based on H&E alone, that can be a very difficult differential. P16 positivity, and if you have a HPV testing available that it includes HPV type 33, that can help confirm a diagnosis of HPV-related multiphenotypic sinonasal carcinoma. There is adenoid cystic carcinomas are often driven by MYB or MYB translocations. And there is a MYB MYB immunostain that's often overexpressed in adenoid cystic carcinomas, but it can be overexpressed in this multiphenotypic sinonasal carcinoma as well. So the immunostain may not be helpful, but if you have the MYB FISH in your laboratory, the HPV-related multiphenotypic carcinomas are typically negative for the MYB translocation. The surface epithelial dysplasia, that could be another feature that could be helpful, right? HPV-related sinonasal carcinomas typically show that carcinoma in situ, like CIS, surface epithelial dysplasia, that should not be present in adenoid cystic carcinoma, which is derived from these subepithelial seromucinous glands. And then another question, if you have an extensive small blue round cell tumor that extends to the orbit, how do you determine the primary site? So that extends to the orbit. How do you determine the primary site? So I guess trying to decide whether it really is sinonasal or not in origin. That's a terrific question. And for cases like lymphoma, if it turns out to be CD45 positive, then it may not be too critical to identify the primary site as sinonasal or not. So it really does depend on the histomorphology and the radiologic correlation. A lot of the tumors that we discussed, like rhabdomyosarcoma, may not be specific to the sinonasal tract in particular. Okay, let's see.
So hi, Michelle, thank you so much. I think this has been really amazing, wonderful talk. And give me 1 second. Sorry, I got the background. Here we go. Really excellent. Thank you guys so much for your questions. I think you answered all of the questions live, and we don't have any more that are popping up.
Oh, terrific.
And we're a few minutes before the hour, so I think we can give them back their time. Again, thanks everyone for joining us today. I think this is hopefully you all enjoyed this. I noticed that we had quite a few people stay on the entire time, which is great. And you can review the recording at your leisure. This is the level and quality of lectures that you can expect from this series. So please share with your colleagues so that they are all excited to join us. And we will see you on Thursday at 3 p.m. local Nigeria time for the next session. You already have the link to register for that. It was sent out to you. And then you can go ahead and do that. And then by Friday, you will have the full landing page, which will list all of the lectures that are coming up, and you'll be able to register for those about 24 hours before the session, and we recommend you do that so you don't have a lot of conflicting links. Again, thank you so much, Dr. Machiro Nishino from Beth Israel, for this amazing lecture. I learned a ton, and we will see you all on Thursday. Thank you.
Thank you all. Have a good day.